Sounds great.
Okay.
All right. Good morning, everyone. Really appreciate y'all joining. Happy Friday. Thank you for joining us today to get the latest on women's hormone health with Lisa Grissom. We have an hour planned this morning. And if you're new to these EO exchanges, in our last 15 minutes this morning, we especially want you to make connections. And so we'll be doing that via small group, and Zoom will just kind of set us up in some small groups. So please stick around for that. We'll give you some thoughtful prompts and questions to get the conversation going when we do get to that point, so don't worry about it. We have 30 minutes planned for Lisa to speak. And then as always with our EO exchanges, we have time set aside for Q&A. So please go ahead and put those into the chat as you think of questions. Without any further ado, I'm going to go ahead and introduce Lisa because I know we're all here to hear her speak this morning. So Lisa Grissom is a family nurse practitioner and a women's health nurse practitioner, excuse me. She's also a hormone optimization specialist and has devoted her career to helping women and their partners optimize their hormones safely. Lisa is the owner of Profiles Laser and Medical Aesthetics in Gallatin, and also Restore Hormonal Vitality and Wellness Center in Brentwood. Lisa, thank you so much for being here, and I'm going to turn it over to you.
Thanks. Okay, hi, guys. I am happy to be here. I love hormones. I'm passionate about them. And I just want to let you know that my goal today is just to clear up confusion. A lot of people are scared of hormones, and I wanted to kind of take a dive into that and explain where that comes from. My goal is to educate you so that you or someone you love can make an educated, informed decision about your hormonal health. Hormones are so powerful. You know, they're extremely powerful substances that are so important to our health and our well-being. I think of them as the Wi-Fi for our body that makes so many of our functions work, and they coordinate everything. As we all know, women begin to lose their hormones in the perimenopause period, and that can last for years until they eventually enter menopause. And of course, that's the absence of all hormones. And we all know that most of the symptoms that are associated with when your hormones start to go awry, and then when you have none of them, are, you know, the hot flashes, the night sweats, the mood swings, the irritability, insomnia, vaginal dryness, lack of libido, lack of motivation. Women are depressed, they're gaining weight, mostly in their bellies. There's changes in their skin and in their elasticity. And these symptoms definitely affect quality of life and a person's well-being for sure. But sadly, behind all of the symptoms, when women are living in a state of hormone deficiency, most women don't know this, they've lost their innate protective systemic health benefits that help our own bodies fight against absolutely every disease that we associate with old age. Osteoporosis, memory loss, dementia, Alzheimer's, you know, macular degeneration, colon cancer, breast cancer, vaginal atrophy. The list just goes on and on and on. So what I do as a hormone optimizing specialist is I optimize the hormones. And when we do that, that brings back vitality, and women have energy, and it addresses their mood swings. They can sleep better. They're able to support lean muscle development, which will definitely eventually lean out that visceral fat that we get in our bellies. It's just quality life and a sense of well-being. So when you understand how great hormones are, why are women so scared to go and replace them? And that's really what I want to address, so that you understand where this confusion and this scare comes from, and hopefully that'll just better equip you to make decisions about your own hormonal health. Okay, in order to do that, I have to go over a study called the Women's Health Initiative. And I know studies can be boring, so I'm not going to, I've tried to just pick out some key phrases and words that will put that study into context for you guys so that you can understand it. Most women are afraid to do hormone replacement therapy because they've read or they've heard somewhere that it's going to increase their risk of breast cancer, or it's going to increase their risk of heart attack and strokes. And so that's really what I'm going to delve into today. We have to talk about the Women's Health Initiative, which was a giant study. There were tens of thousands of women in the study. And almost everything you've read or you've heard about hormone replacement therapy for postmenopausal women is influenced by the Women's Health Initiative. Even though it's now almost a 20-year-old study that was stopped abruptly in 2002, it still just has so much weight. Okay, so I'm going to start my PowerPoint and jump in. Okay, so here we go. Hormones, are they good or are they bad? So this right here is hey, Foz, can you make that go away so I can see everything? I have my IT expert son with me. Okay, so this is a direct quote from the Women's Health Initiative. On May 31st, 2002, after a mean of 5.2 years of follow-up, the Data and Safety Monitoring Board recommended stopping the trial of estrogen plus progestin versus placebo because the test statistic for invasive breast cancer exceeded the stopping boundary for this adverse effect, and the global index statistics supported risk exceeding benefits. That is a direct quote from the Women's Health Initiative, and it's basically saying that the safety board recommended stopping the study because there were too many cases of breast cancer in the study group that were taking hormones. This next slide here is another quote. It says, quote, the 26% parenthesis 38 versus 30 per 10,000 person years in parentheses observed in the estrogen plus progestin group almost reached nominal significance. So when you read that 26%, when the authors list that, a 26% increase in breast cancer, it sounds very scary. But what we need to understand is that 26% is a relative risk increase. It didn't mean that there were 26% more people that got breast cancer. The real active risk is what relative risk is what's commonly used in research papers, and it sounds a lot more scary than it is. The key is in the parentheses. That's where we find the truth in the detail. Hey, Foss.
You just hit next.
It's not going.
Click.
Sorry, I'm having technical difficulty. Okay.
Yeah, so you can just click
So right there, just click.
or here.
Okay. So right there, that 26% increase, let's look inside the parentheses. That's what tells us the truth. The statement says 38 versus 30, which means that 30 out of 10,000 women were at risk to develop breast cancer without hormones. Then when they added hormones, the Women's Health Initiative estimated that hormone replacement might increase that to around 38 women with breast cancer in a group of 10,000 women. So That is actually the absolute increase. So the absolute increase in breast cancer was really around 0.8%, which was an additional 8 cases a year. And that sounds a whole lot different than a 26% increase in breast cancer. Again, I want to read this quote because it's just crazy to me what happened with the medical media and this research paper. Almost, well, I want to focus on that word. The 26% increase almost reached statistical significance. Almost reached statistical significance means the same thing as did not reach statistical significance. If something doesn't reach statistical significance, then it's exactly saying that it didn't reach it. And that by definition means the statistics show that it could have happened by chance. It's most likely not caused by hormone replacement. But what happened in 2002, it was sensational, it was shocking. And the medical media, the newspapers, it's all over the news. I remember when my mother quit taking her hormones. That was the sensation. And sadly, there was never a circle back around to really talk about the absolute risk really being only 0.08%. So that I wanted to make that point. And then another thing from the Women's Health Initiative, this is a quote straight from there. It says this trial tested only one drug regimen, which is conjugated equine estrogen at 0.625 milligrams plus medroxyprogesterone acetate at 2.5 milligrams in postmenopausal women with an intact uterus. That just means women who had not had a hysterectomy. The results do not necessarily apply to lower dosages of these drugs, to other formulations of oral estrogens or progestins, or to estrogens and progestins administered through the transdermal route. Okay, this is an explicit statement in the report from the Women's Health Initiative, but it's been completely ignored by physicians organizations and by the FDA. And it totally translates to a treatment regimen out of what was just listed. Okay, so I just wanted to make this clear. In the Women's Health Initiative, they were using synthetic hormones. And the CEE stands for conjugated equine estrogen, which is a synthetic estrogen that is derived from pregnant mare's urine. It's essentially from dried horse pee, and it contains 10 to 60 estrogens, mostly only found in horses. Women, our human bodies only make 3 estrogens. And in the conjugated equine estrogen, which we call Premarin, there's less than 5% of estradiol, which is our most potent female human estrogen. And then also in the study, they used a synthetic progestin, which we call Provera, but it's truly medroxyprogesterone acetate, and it's 20 to 40 times more potent than natural progesterone. And its function is to prevent endometrial hyperplasia, which just means it makes sure the lining of the uterus doesn't get too thick. And in this study, some women that had had a hysterectomy were not given Provera or this medroxyprogesterone. So back from that earlier statement that I read to you, results do not necessarily apply to other hormones, doses, and combinations. That's a very important statement, and it's just been overlooked and not recognized in the medical world, but very pertinent when someone like me who works with natural hormones. It's just a shame that things are cherry picked. Okay. So all of that led to a black box warning that comes with any type of hormone therapy. there's a warning on any and all of hormone replacement therapy in bold print, warning patients about the dangers of HRT, even though the study itself says that you cannot apply these results to other hormones. There's another arm of the study that talks about unopposed estrogen. This is an arm of the study where they only gave women the Premarin, the compounded equine estrogen, and they did not give them progestin. And that they did this with women who had had a hysterectomy. And what they actually showed in that arm of the study, that there was actually a decreased breast cancer risk. And this is just a point. It's not conclusive, but I think that it hints at the fact that the synthetic estrogen Premarin was unfairly demonized, that maybe it's truly the medroxyprogesterone that's causing this slight increased risk of breast cancer. And another point to make about the Women's Health Initiative is that the mean age of the women in this study were 63.3 years old. So the average age that women usually go through menopause is around 51 years old. And the patients in the Women's Health Initiative had already gone through menopause. Most of them had been through menopause for 10 to 12 years before they entered the study. So if you remember back when I was telling you that our hormones are protective and they protect us against all the diseases we associate with old age, here you have a population of patients that they used in the study that had lived in a state of hormone deficiency for 10 to 12 years. And so the roots of all those diseases we associate with old age had probably taken root in their health. The title of the Women's Health Initiative I find interesting. The title is Risk and Benefits of Estrogen plus Progestin in Healthy Postmenopausal Women. But really, just how healthy was this population of women? The statistics are written right here. The average BMI was 28.5. So on average, all the women were overweight. 50% of the participants had smoked prior or were current smokers. 4.4% had diabetes. And 12 to 13% had high cholesterol. And 7% of those were taking statins to address that high cholesterol. 36% of these women had hypertension. 1.6 to 1.9 had a history of heart attack, which is incredible to me that they were included in this study. When you look at all those statistics, I wouldn't classify that as a very healthy group of women. So with all that being said, what I do and practitioners like me do is we work with bioidentical hormone replacement therapy, but we have to deal all the time with the fears that come from the Women's Health Initiative and how that was portrayed in the medical media and how it scared people. The difference in bioidentical hormones and the synthetic hormones, which is what was used in the Women's Health Initiative, is that bioidentical hormones are made from plant sources. Of course, they've had to be taken into a lab and changed into a delivery form so that we can get them into your body. But the molecular structure of them is it's identical as what our own bodies make. Bioidentical hormones, the chemical structure is the same as natural estradiol, not equine, conjugated equine estrogen. What I do is I optimize hormone levels to what they were back in their 20s. Anyone who does what I do, that's our main goal. And a big thing that I feel is important to teach my patients is that within normal limits on lab values does not always equate to optimal. I'm 57. I am definitely postmenopausal. And if I was not taking any bioidentical hormones and I sent my labs off to be tested, they would come back. I would be deficient in estradiol, progesterone, and testosterone for sure. But they would not flag me as low because it's normal for a postmenopausal woman to not have any hormones. So they wouldn't flag me as low. So if you're coming from the mindset where you're just going by that lab and all you're going to do is address anything that's high or low, then you're not going to address that. Within normal limits truly does not equal optimal for women when we're trying to live in a postmenopausal state, because you're going to feel awful. You're going to have no energy. You're going to be depressed. Your joints are going to hurt. You're going to be getting belly fat. You absolutely have no libido. If you do have intimate relations, it hurts because of vaginal atrophy. You're depressed. You can't think. You have brain fog. So that's why we replace hormones. And I just want to make the point that none of the risk associated with the synthetic hormones, which we just went over in the Women's Health Initiative, applies to bioidentical hormones. You're not comparing apples to apples, you're comparing apples to oranges if you just take those results and blanket them over all hormones. So that's kind of the end of my presentation. And I couldn't talk way more about it, but I really wanted to just, I don't know if that clears up the confusion, but that is where all the scare comes with hormones. There was one more slide. So this is just my contact info. I'm not on here soliciting business, but if you have more questions, you can reach me here, and I would tell you I can give you more resources. If you're looking for a practitioner that optimizes hormones, you can look on a website called worldlinkmedical.com. There's a lot of well-trained practitioners on there. You can look on a website called Biote, BIOTE.com. A lot of great practitioners on there as well. We can talk about different delivery methods with bioidentical hormones. I'm happy to answer questions.
Lisa, thank you so much. Let's go ahead then and move into the Q&A as Lisa suggested. So I know some folks have already been putting questions into the chat. Lisa, are you able to see those? And if so, could you read a question, read a question and then go ahead and answer it?
Hey, you know what, Lisa, we'll read them to you. Will that be easier?
Oh,
Yeah,
great.
that'd be
Thanks,
great.
Marla.
Perfect. Okay. So I'm just going to start at the beginning. So, and I'll just go in no order because they're really starting to pop in really quick. So I think we're about to bend your ear for a minute. So Dusty is asking, what makes estrogen high? What contributes to this?
Okay, well, estrogen, when women are in perimenopause, that's when our hormones start to go awry. Okay, so a woman can be having normal, regular cycles and regular periods, but behind the scenes, when we're looking at labs, when their FSH starts to climb, then as a practitioner, they're going through periods where they're having estrogen deficiency. And in perimenopause, it's just crazy. One day your estrogen can be 75 and the next day it can be 300. And when you say what causes that, well, that's a great question, but it's just that time in your life when your ovaries are starting to not produce consistently. And so that's why you get all these fluctuations. And that's what causes in perimenopause mood swings. You just don't feel like yourself. One day you're fine, the next day you're happy, and then you're crying. It's a miserable time. So I don't know that I answered that, but I hope that helps.
Can I just say one thing? My specific was on estrone, which I know is more of the cancer-causing estrogen.
Yes.
And mine has always been high, and that's why I was wondering if you can say what is the cause for that specific estrogen to be high.
Okay, so with estrogen, we metabolize our hormones down different pathways. There's the good, the bad, and the ugly. Okay, so the good is estradiol. Then we have estriol. So there's the good, the bad estriol, and then the ugly would be estrone. And estrone is the one that we associate more with cancer. What I would recommend to you is that you take a product called DIM. I don't know if you've ever heard of DIM. It's a very long word, but what it stands for, it's an acronym. DIM is an acronym for this long word that is the main ingredient in cruciferous vegetables. And so if estrogen's high, I would definitely have someone on DIM every day, because what that does is it helps to ensure you're going to metabolize your estrogen down the healthy pathway.
Okay, thank you.
Perfect. Okay, and then follow-up question. If your thyroid tests are normal, what is the way to make T3, T4, or T3 levels where they should be if you have a slow metabolism and find it hard to lose weight?
Okay, so I didn't go into that at all, but that's definitely something that practitioners like myself do. And quite honestly, it's the most controversial in the medical world, because we are really trained in the medical model to just address that which falls out of within normal limits. But if you have a patient sitting in front of you, or if I have a patient sitting in front of me and they're tired, a big clue to me is they say, I have no energy. I sleep all the time. I wake up and I want to go back to bed. To me, that's a huge clue. We've got a problem with the thyroid. You can have all the clinical signs of a low functioning thyroid, but your labs, your T3, your TSH, your T4 falls within normal limits. And the way to address that is to, I use, and anyone who does what I do, we use desiccated thyroid, which is like Armour thyroid. I don't know if you've heard of that, or NP thyroid. Our thyroids, we could talk a long time about thyroids, but our thyroids make T4 and T3. And traditional medicine focuses a lot on TSH, which stands for thyroid stimulating hormone. It's a test that basically just tells us how hard our thyroid's working. And then traditional medicine throws Synthroid at that problem. If it's flagged high, if the TSH is flagged high, they throw Synthroid, which is just T4. Well, our thyroids make T4 and T3. T4 is inactive. It has to get broken down into T3 so your receptor sites can pick it up and use it. And that's what I focus on to guide that kind of therapy, is your T3, because that's what causes changes on a cellular level that people can feel. And what that means is energy. What that means is better metabolism. What that means is better mental clarity. Addressing thyroid function can really be life-changing for people, but it's certainly it's certainly the most controversial thing that I do, to be honest. I get callbacks from patients because they've gone to their traditional primary care physician and they don't want to treat the patient, they want to treat the numbers.
Right. So you answered the question about if tests appear normal, and then do you recommend a saliva or a blood test?
There's controversy in that. I mean, it depends on what camp you come from. I think it's fine to get a baseline for your hormones with saliva. But I follow my patients, anyone who's trained like me does. We don't just give you hormones and send you out the door. We have to be monitoring those levels to make sure we get you optimized. Once you're optimized, then we don't have to test the blood as much. If someone is really interested in what's going on with their adrenals, I think that saliva testing is definitely the way to go. I use blood. I do serum testing in my practice, but I do know there's a lot of practitioners who prefer saliva.
Okay, perfect. Okay, here's another question. At what age do you recommend someone have a consult?
Well, I think that, I treat people in their early 30s. It really depends on what's going on with the individual. it's really hard to just say an age. I have a sister-in-law that went through menopause naturally at 28 years old. So you can't really pick an age. It's more how they feel. Most people have this innate feeling when they know that something is off with them hormonally. And that's when I would seek out a consultation.
Okay. And then how quickly do people typically feel results?
People typically feel results, to give the practitioner a little leadway, we're going to tell you 4 to 6 weeks, but you're going to feel it before then. I mean, if you're really deficient, you're going to feel it. I would say within 10 days to 2 weeks.
Okay. And then the follow-up to that was if no results, what happens next?
Well, I don't typically see someone that's living in a state of hormone deficiency not respond to hormone therapy. If there are no results, then I'm looking at the blood levels, because you've got to take into account what's happening with the labs and with what the patient's telling you. And when you say if there's no results, well, then we just haven't gotten that person optimized.
Great. And then, so when they start on you don't really call it a treatment. So what kind of explain to us the process a little bit?
The process of treatment,
Yes.
how it works in my practice is it's much more time efficient for the patient and for me if they will have their labs drawn before we meet. And then when we do, we sit down. Of course, we go over medical history. We go over their signs and their symptoms and what the labs are showing us. And then we discuss delivery methods and what feels right and fits right into that person's life. And then we prescribe them. I work with compounders. I get my hormones compounded, that you don't really get them from like CVS or Walgreens. They're not manufactured drugs. They're made specifically for the patient. And then we prescribe them. Typically, depending on the delivery method the patient's chosen, I will ask them to have their labs drawn in anywhere from 4 to 8 weeks after we start. And then we sit down and we look at the changes in the labs and the changes in how they feel, and then we adjust accordingly.
Okay, perfect. All right. So here is a question, and I'm probably going to butcher this word, but I'm going to give it my best. Do you work with women on tamoxifen, so TAMOXIFEN, or have breast cancer history?
Okay, I do work with women who have breast cancer history. A woman who's taken tamoxifen, that is basically a blocker for hormones. And so, no, that would be counterintuitive. I wouldn't do that. Mostly, what typically happens is a woman who has a history of breast cancer, if they're like 5 years out, or if they have their oncologist is forward thinking and they're out there, they're in Nashville, and they understand, then we can treat. I always do that with permission from the patient's treating oncologist.
Okay, great. Here is one. If one's adrenal is normal but showing signs of fatigue via straight line cortisol levels, could this be hormone related?
Absolutely. It's your hormones, all of them are, it's like a symphony. And you take, I'm not a musician, but you take the string instruments out, it's going to affect everything else.
Perfect. Okay, here's one. Can you give us some good examples of people who would not be good candidates?
Well, that's interesting. I can give you examples of people who are not good candidates for certain delivery methods, but I don't think anyone is not a candidate for hormone replacement. Now, you do have to look at, their cancer history, blood clotting disorders, yeah.
And then when you were talking to us about the study that was done in 2003 and what's come from that and kind of how it was skewed a bit from what you were showing us on the facts and stuff. So side effect, like what are the side effect, like the pros and cons, if you had to do it real quick, like 3 pros, 3 cons, or are there cons?
There really aren't cons to optimizing your hormones. The cons would be if you were working with someone who wasn't like checking your levels and listening to you, because there's a sweet spot with all your hormone levels, and too much is bad, just like too little is bad. There's a sweet spot. So, I do a lot of testosterone replacement, and there can be cons with that. If you get too much, there can be cons with any of those hormones if there's too much.
Someone jokingly said, was a man in charge of the 2003 study.
That's interesting. If someone really wanted to delve into the Women's Health Initiative deep, there's a book called Estrogen Matters. It's written by, I can't think of both the authors, but one of them is Avron Blooming. And, you really, sadly, there's politics and greed involved in everything. And they go into detail about how that got intertwined in the study.
Gotcha. And then, so let's talk about this real quick. So, and I'm reading questions, and then someone just texted me one. So if someone knows they're in perimenopause and then someone knows they're in postmenopause, 2 different plans, everybody's individual, I guess, but is it too late to get started? Is it too early to start? Kind of talk about that little timeline.
Well, ideally, a woman doesn't go for more than 10 years after she's gone through menopause. Her risk of developing things like those diseases we associate with old age are greater. But no, you definitely can treat perimenopause. And if you treat perimenopause, going through menopause is so much more gentle. Definitely. And with bioidentical hormone replacement therapy, I get this question a lot. When do you stop? Well, my mother's 80. When would I look at my mother and say, okay, Mom, sorry, you've hit that age. You're going to have to feel bad. We're going to have to let your bones go. You don't stop. It's well-being.
Okay, great answer. Here's a question. If someone was going to go ahead and get their labs drawn prior to coming for a consult, do you have specific labs you would suggest?
Oh, absolutely. We look at their free and total testosterone. We look at their estradiol level, their progesterone level. Our first labs are kind of comprehensive because, we're looking at the total health of the woman. But we look at those, we do a thyroid panel. I look at their vitamin D. I look at a CBC. You want to see in a complete metabolic panel, you want to make sure there's no plating, there's no anemia or platelet disorders. But we focus in on the hormone testing as we move forward, depending on what hormone we're treating.
Gotcha. So if someone made an appointment, you would help them get the lab stage done. You would direct them how to do that.
Oh yeah, we would email a lab requisition to them and they would take it to a Quest, or if they wanted to go to their doctor and use a different lab, we'd send a different requisition.
Okay. Here's another one. Most, if not all, of the natural hormone replacement clinics that this person has researched do not take health insurance plans. Why is that? And do you know of any that do take health insurance plans?
I do not. And we don't take health insurance either. And the reason for that is health insurance generally is in bed with big pharmacology. And so they're dictating how that practitioner practices. And big pharmacology doesn't want, they're always fighting what we do because they don't want us doing what we do. What bioidentical hormone replacement therapy, when you get someone's hormones optimized, you're helping that person be protected from all of those diseases that big pharmacology wants to treat. So they just don't go hand in hand.
And then someone has asked, what type of cost, since insurance doesn't cover this, like kind of walk us through the price structure?
Well, that depends on the delivery method and definitely depends on the clinic or the practitioner that you choose to go to. That's a hard one to answer. I could tell you about ours, but I can't tell you about everyone. A lot of these clinics will do like a concierge type practice and you're paying them by the year. We choose not to do that. If our patients that choose creams and oral medications are a different price than our patients that choose pellets.
Okay. And then Rebecca has thrown some stuff in, some recommendations, and then Dusty threw in a book recommended on how to achieve healthy aging by Neil Rotter, Routtier. And then Rebecca's saying she is going to see Brooke Fraught and cannot say how different she feels. So cannot say enough about it. So that is awesome. Okay. Any other questions before we go into breakouts? You're welcome to pop on and ask, or you can put it in the chat. I know y'all are not shy.
And Marla, I'm going to stick the link to fill the survey out in here really quick. If everybody will do that as soon as we're done with the breakout rooms, that would be great. Then in a minute, Marla, do you want to put the questions in here, or do you know
Sure.
questions you want them to talk about?
Can I
I
ask
see,
one?
I see a question. It says, can you explain pellets?
Yeah.
Yes. Pellets are a transdermal delivery method. Okay. It's just like the cream. With testosterone, you can't give it to a person in a pill form because it's going to be metabolized in their liver and it's toxic if it goes through your liver. So that leaves us with having to deliver testosterone through a transdermal delivery method. So that's either a cream or a pellet. I personally was very slow to come to pellet therapy because I had a huge bias against it. I didn't really start doing pellet therapy till, I guess it's been 6 years. And now I feel really bad that I talked people out of it. I mean, I have all the talking points to scare people about pellets because I was scared of them. It's truly just another delivery method. The problem with creams is compliance. I mean, it doesn't work unless you put it on every day. And I know that sounds crazy. For some reason, we women will put all kinds of cream on our face, but to put on a hormone cream, it seems to be a challenge. So that's the difference. The pellets are, it's a procedure. It's a little sterile procedure that we do in the office. They're tiny. They're about the size of the grain of rice. On average, women get their pellets every 3 months. I say 2 to 4 months, and that's a big leadway of time. But what determines that is how active that person is. The women that I work with that are really active, big exercisers, they're going through their pellets much more quickly than the women that aren't moving a lot. So I just tell people on average every 3 months. We can put estradiol in a pellet and we can put testosterone in a pellet. We don't put progesterone in a pellet. Ideally, you take progesterone at night before you go to bed. It's one of my favorite hormones. It's God's gift to women. It's like a natural Valium. It quiets your mind down and it helps you sleep. Yeah.
Love that. Well, I'm going to turn it over to Brooke to kind of lead us into the Q&A section. This has been great. Thank you, Lisa.
Thank you.